So we're going to talk about sites of compression for ulnar nerves. So there's 5 sites for the ulnar nerve: the MIS, the arcade of Struthers, the cubital tunnel. So there's 3 areas of compression when it comes to the ulnar nerve, right? And I think the most common one obviously is a cubital tunnel. And the cubital tunnel one, they're looking at the bottom of the cubital tunnel, you have the elbow capsule and the medial collateral ligament, the FCU and the ligament of Osborne. The cubital tunnel is slack when it's in extension, and then it's taut when it's in flexion. So that's, I think, some of the most important aspects of what you want to know when it comes to cubital tunnel compressions. The arcade of Struthers is the coracobrachialis tendon, the fascial muscle fibers of the medial head of the triceps, and the MIS. So for the most part, those are the sites of compression. And then in terms of other problems that happen in the ulnar nerves, you're going to have subluxations. No, I actually tried to look for that and I could only find that it was called the MIS. That I looked through the whole, no, the Guyans is down here. So I drew a whole thing for that. In terms of the ulnar nerve, you have the compressions here at the elbow, and then you have the compressions here at the wrist, right? So right now the compressions are here at the elbow. The arcade of Struthers is also at the elbow. The cubital tunnel is also at the elbow, and the MIS is also at the elbow, but they're compressions. And then you have subluxations that can happen to the ulnar nerve as well. And it could be due to the laxity from the bands. So with the ulnar nerve, you can have 2 types of problems. You have compressions or you can have subluxations, right? So when it comes to the subluxations, it's just that nerve is just like flipping and flopping around, and it can be due to the laxity, right? And there's 2 types of subluxations that can happen. The 2 types are when the ulnar nerve moves to the tip of the epicondyle, when the elbow is in flexion greater than 90 degrees, right? So there's 2 types of subluxation. So one of them is the ulnar nerve moves to the tip of the epicondyle, right? And the other one is when the ulnar nerve passes completely anterior to the epicondyle when the elbow is fully flexed. So one type just moves a little bit and the other move goes all the way, right? But the first type is 75% of the subluxation, right? So 75% of subluxations are, it moves to the tip of the epicondyle when the elbow flexes greater than 90 degrees. This is my flexion sign. Greater than 90 degrees. The other one is when it goes all the way through. All right, so those are 2 types, but this is the most common one. There was a tidbit in there that I thought was really interesting. There's a muscle anomaly, the aconus, is associated with prominence, the medial head of the triceps. So sometimes it could feel like that's what's going on. That could be causing some of the ulnar nerve types of issues. 3 grades. The first one is mild. You've got mild numbness and you're a little bit clumsy, right? Grade 2 is you've got weak interossei muscles and muscle wasting, which is atrophy. And then the third one is paralysis and atrophy with marked weakness. So I think that when it comes to the ulnar nerve and its compression sites, those are really important to know, just to know them. But a lot of your elbow problems are going to start here, and it's important to know like the arcade of Struthers and stuff like that, as because it pertains to ulnar nerve. So there's other key names that you're going to start to see like in questions and stuff like that. And the most important thing is that you have to differentiate which nerve is it. Because there's like the frost, right? What was it? I wrote it down. Oh, the arcade of frost, right? So arcade of frost is radial nerve. Arcade of Struthers is ulnar nerve. So when it comes to structures like that, it's important to know, okay, here are the compression sites of an ulnar nerve, right? You've got 3 sites here at the elbow, and then we'll talk about the compression sites at the wrist, because they're completely different. Do you really need to know the specifics? In a way, yes, right? So if you're talking about the cubital tunnel, the bottom part of the cubital tunnel is the elbow capsule, you know, and of course the medial collateral ligament is there as well. The FCU is important to know, because if something's going on with the FCU, that could be a part of it as well. You know, that's a little bit of problematic when it comes to, you know, cubital tunnel types of issues. But it's important to know that there's like those specific structures. Do you have to draw it out and all that stuff? Like, I don't think so. You just have to recognize the names, and if you can know your anatomy in that area, you're going to know it's 1 or 2 of those muscles, 1 or 2 of those things. And of course, the tricep plays a role too, right? Because the anomaly, the conus, is associated with the prominence of that medial head of the triceps. Clinically, I've seen people who have ulnar nerve issues, if we work out their triceps, it really helps them. So there's something to be said about that particular, the conus, and being associated with the medial head of the triceps. So I thought that was like a key thing. It is important to know the grades, you know, in terms of mild to moderate to severe, because then it's going to go into what you need to do as a therapist. Like when I read through these chapters and I think, what do I need to know? What should I focus on? The things that I want to focus on are the things that are going to be really relevant to me as a clinician. So I only need to know these things enough to know this is what I'm going to see clinically. And then what I see clinically is how I can help them, right? And so on the test, there's going to be so much of that. So if I know that the question is going to be like, if it's mild and this and that, if they do the test and they have intermittent numbness and stuff like that, can you help them conservatively? Sure. If you already see marked, you know, paralysis and weakness and atrophy, you know, what is the grade? How severe is it? You know, what would your recommendation be? Then it's like, yeah, if you're already in the severe part, then they're already talking about surgery, right? They're already talking about the different types of surgery. And when you think about, we're going to go briefly over the surgical stuff, why do you even need to know some of the surgeries? You know, it's just enough so that you can treat people. So when it comes to ulnar nerve types of issues, what are their symptoms? What are they going to be telling you? They're going to have pain at their elbow, right? They're going to have numbness to the ring finger and the small finger. A lot of times they're going to have night pain. Remember, you know, if they're sleeping like this and there's a lot of elbow flexion, well, elbow flexion is putting pressure into that area, right? Putting pressure into the cubital tunnel, into the arcade of Struthers, that kind of stuff. And so you're going to have that kind of night pain. And it's worse, gets worse when it becomes constant, right? So when you have intermittent, like, oh, it bothers me here and there, but when it gets worse and there's increased pain, there's decreased grip strength, right? You're already into grade 2 and 3. Obviously, when there's clawing of the fingers, and then when there's abduction of the small finger, right? So a couple of things in terms of testing will be the Tunnels. I'm not a huge fan of doing that, but you don't have to know how to do it. You just have to know that it gets done, right? So if you're positive for Tunnels at the elbow, right? At the elbow. and you're positive for a cubital compression test. So Tunnel, you tap, it's right here on that, it's the most superficial nerve that we have in our arm, and you tap it really hard and it sends a sensation down, that's positive. Cubital tunnel compression, well, you know how to do it because you know that with flexion puts pressure onto that nerve, right? So how you're going to test it is just have them bend their elbows and keep it for a minute. And if they notice any sensory changes, then that's positive for that. And the other one is if they do an EMG. So why do we need to know that? It's not that because we're going to do it, but if the signal is less than 41, millimeter per second, then that means there's decreased signal. So I thought that was important in terms of like if they're going to ask you questions as it pertains to how would you test, what would the appropriate test be, right? For someone who had, how do you differentiate? So a lot of the test questions aren't going to be so simple, but how do you differentiate stuff is always the top type of question on the exam, because you do so much about therapy is like ruling in and ruling out. Is there conservative treatment? Absolutely. How much of it depends on who you ask. The book says there's conservative treatment, and I'm a big fan of conservative treatment, but you do have to know who that person is, what's going on, where it is, when it happens, why, and to what extent. And that's going to help you grade through like the severity and what you're picking to do. As with anything else, you're just going to rule things out, rule things in and rule things out. So ruling out thoracic outlet syndrome types of stuff. Cervical, remember the Sperling's test? Turn, look down, press on the head. That's so you're going to rule out. All that test does is rule out there's cervical bone problems, right? It's not, doesn't differentiate anything. It's just saying, well, it's not the bone, the cervical neck bones. You can test, rule out for dermatomes. Then, of course, to rule out thoracic outlet syndrome stuff is the East test or the Ruse test, right? Ruse test is you're just asking them to go into external rotation, abduction, and then they're just going to pump their hands up and down like this for 3 minutes. 3 minutes, like, my ass is going to be tired. But what happens is they start to have like a lot of sensory changes and problems and stuff like that. So then they'd be positive for a Ruse test. Anyone who really does have thoracic outlet syndrome like won't be able to do that. And I don't know if I'm going to say this correctly, and someone could totally fix me. Serous test. I know how to do it. Did I spell that right? No. IX Serous test. Like they're just sitting and you take their arm and their shoulder blade and you just lift it up. That's all it is. You're looking at unloading the scapula, right? And if it alleviates their symptoms, then they have thoracic outlet syndrome types of issues. You can actually do that with just pillows. Like you can have someone self-release, but that's like a treatment. But these are some of the tests that you could use to rule out, because any kind of nerve compression stuff is just ruling out. So especially with ulnar nerve stuff, you're going to rule out thoracic outlet syndromes and stuff like that. You're going to test from proximal to distal, right? Because you just, you don't know, like somewhere along the way, they could have something, right? So you're testing all those neck, thoracic types of area stuff, then you'll do here at the elbow, and then you can check at the wrist. So when it comes to treatments, you're looking at muscle length, myofascial. Most of the time, people with ulnar nerve problems don't necessarily have joint issues, but they may have muscle length issues. Treatment. So here you're going to be looking at muscle length. You're looking at myofascial. You can do neuro mobilizations, right? You can do orthosis, and then you can do activity modifications. So it'll work out any muscle length types of issues. Again, if you've got forearm tightnesses, like FCU types of issues, triceps, so you're going to go work below, work above, Could be anything in the cervical area that can be tightening, myofascial types of stuff, which I think really can go well with the neuro mobilization types of treatments, because when you're getting them to move through, you're going to move everything, right? Orthosis is really temporary and just protecting, and it tends to be for more severe cases. Just because someone comes in with ulnar nerve types of issue doesn't mean you have to like splint everybody. But the splint usually is an extension splint for sleeping, because you don't want flexion. And then activity modification. So, you know, you can modify their stuff. I'm a big fan of like temporary, you know, activity modification, but ask a young person if they want to modify their like forever, like nobody does. The biggest thing is the neuromobilizations, just making sure that you're not overdoing it, like you're not overstretching someone. Overstretching, 78% can cause a decrease in blood flow, right? So the whole point of neuromobilization is to move outside the nerve, the stuff outside the nerve, and also to move inside the nerve. So they use words like extraneural and intraneural, inside and outside. That's it. But you can hold the area of compression static and then move the hand or wrist, especially with the nerve on slack. So the whole idea of neuromobilization is basically, again, it depends on the severity, but the idea of it is you don't want to take that whole nerve and just take it and stretch it and yank it, right? You're going to hold certain part, you're going to hold wherever you think is irritated the most, stabilize that, put everything on slack, meaning you're going to put it in a shortened position, and then you're going to move the distal part so that that nerve can gently move and that gently glide. That's all it is. And they talk, it's very specific, slow rhythmic motion. So it's not like your typical exercises. And it's actually really important because when you're doing it with people, they have a tendency to think that it should be, like they should feel everything, right? But if you have them feel too much, it can become a problem. This happened to me very young in my career when I was like, oh yeah, neuromobs. And then when you get someone in a heightened state, you'll like exacerbate their problem and then you lose all trust. So if you suspect nerve issues, you actually want to go like slower versus faster. And then the directions around it are really key. But that's the most important thing when it comes to like those neuromobs. So from a surgery standpoint, right, there's compressions. So all of this post-surgical stuff really all come down to what do you need to know as a therapist? So you need to know the type of procedure, right? Because then you're going to know kind of like how bad it is and what you need to do to treat it. So they have the endoscopic release. They have the in-suite decompression. And then they have the medial epicondylectomy. So these three are to decompress. The doctor would pick 1 out of 3 of these for anyone who has a compression type of problem at the elbow, and they will decompress it. So the endoscopic release is just really small. They get good results. It's very mild. They're in and out. They get one little deep, like super small. Half the time, they don't even go to therapy, right? For the most part. But it's super small. They just go in there and do a little release. This is the easiest that they could do, which probably means like someone's a little bit more mild, right? Mild to moderate type of problem. And then you have this compression. They cut to release the ligament, the arcuate ligament. It's good for those with mild weakness, right? Do we talk about grades 1, 2, and 3? Well, here will probably be like that grade, at least grade 2 and 3, right? So they're saying that this is good for those with mild weakness, sudden onset, mild abnormal sensory action potential, which means intermittent numbness. And the pros are it's easy and it's easy recovery. The con of it is pretty much that you can have a reoccurrence because sometimes it's just not enough, right? So those two are the easiest, but this is the easiest. And then this one is the harder one. This is where they essentially, they decompress, so they're kind of doing all of this. But what they do is they shave and then they file down that epicondyle. So medial, and they remove. So that one is, you know, the results are okay based on the book. Results are okay. And the pros for that is for anyone who has like persistent medial epicondylitis and they need more decompression. So it's probably for someone with a grade 3, someone who's a lot more severe. The con is it takes longer for recovery. And if you take too much off, then you risk elbow instability, right? So those are for your compressions, and there's 2 surgeries for subluxations, right? So these are your subluxation surgeries. You have an anterior transposition, and then you have a submuscular transposition too. So one is the anterior transposition. This is the easiest one out of the 2. So subcutaneous, they move the nerve below the skin and they just, you know, they just move it a little bit to the front. The bad thing about this is for anyone who's really skinny, won't have enough of that fatty tissue there to kind of provide enough coverage. Then there's the submuscular, which is the hardest one to do. And that one is the flexor pronator muscle that they cut and they lengthen over the ulnar nerve. And they do an osteotomy of the medial epicondyle and then reattach the muscles. So they're kind of doing this medial epicondylectomy. They're taking the muscle and they're moving it from one place to another. And then they're going to screw that muscle back in. That's the submuscular. So imagine anytime you are cutting like the muscle off of its attachment and reattaching it somewhere else, like how much time do you think it's going to take? It's going to take a little while, right? It's going to be the one where like everything can start moving right away. Like with these, there's really not much downtime, right? But submuscular, you can't really do anything for another 3 to 4 weeks. So with this one, you're immobilized for quite a long time. So it's just a harder surgery. It's a longer recovery. Obviously, the best decompression because you've kind of like moved everything out of the way. Like if you've moved that much stuff out of the way and shaved off a bone, like there's nothing left to do. So obviously with this, it's a very specific group of people that have this type of surgery. I think I've only seen it like once or twice as it pertains to like someone with a severe elbow fracture and then they have subsequent types of injuries. But I think majority of the time you're gonna see these 2 types being the most popular ones that you're gonna see as a therapist, like you know, people presenting with some ulnar nerve types of issues. Actually, I had a patient who, a friend of mine who did this one, and then she was doing fine for a while, and then her ulnar nerve started to act up. She's left-handed, and she would write, and she's super skinny, right? And they wanted to do an anterior transposition because they're like, oh, you're, you know, whatever, you're probably just rubbing it, but she's like this little stick of a thing, and she writes in the way she does it. I guess it just was irritating it. And after the surgery, she never did any therapy because they don't really see the need to send you to therapy because, you know, like, oh, your numbness is fine, your pain goes away. But what happens sometimes is people don't see that the imbalances are created from that. And so I want to say about 3 or 4 years later, it started to act up again. And she went back to the doctor, and he said, oh, well, if it continues to bother you for the next 3 more months, right, we can do an anterior transposition. That just means I'm going to take your nerve is probably just subluxing, and I'm going to move it from this place to that place. And she finally told me about it, and I was like, are you crazy? Are you crazy? Can we do a little treatment first? And sure enough, I released her tricep, right? Worked all this serratus anterior types of issue, because she had shoulder problems. She was real tight in her shoulder. Done. No surgery. And the thing is, the more she worked out, the worse it was getting. And what was happening was she was working out a lot. Started dating this fitness guy. They started working out all the time. And she was super buff and fit. And then, you know, but if you have these little nuances, it'll create little imbalances. And she just didn't realize it because nothing else was hurting. But what was happening was her elbow was hurting every time she bended, and like her numbness would bother her. And so, yeah, she just needed a little bit of therapy. Showed her exactly what to do and all this stuff. And she got her scapula and all her muscles moving, triceps for sure. I think it's a secret weapon. So got her triceps, you know, released, because remember, it goes through that area. And doesn't really matter like which band was holding her back. Was it the arcata struthers, or what, you know, like, you gotta release it, and that's it. And then you're done. You don't have to have the surgery. But you now know those different types of procedures. And on the test, it could be anything like, which one will your doctor pick based on a scenario, you know? And you might see age, you might see someone super skinny, you might see like recurrent or problems, or it could be like something they've tried and, you know, can't go away. And so at least you can problem solve through it, because you know that there's 3 major surgeries for compression types of issues, and there's 2 major ones for subluxations, right? They're 2 different problems of the ulnar nerve. All right, so the ulnar tunnel, and somebody correct me if I'm saying this wrong, Guyon's canal. And this is much harder. It's not as common, but it's still important to know. But there are 2 branches. So this is how I'm going to draw it out, right? So there's 3 zones. Sorry, there's 3 zones to this tunnel, right? So I'm going to draw. So this is zone 1, zone 2, make a little space so I can draw, and then zone 3, right? So this is 3, 2, and 1, right? And then here is the pisiform. And then all the way down here is your ulna, just so you have some like guide, right? So the ulnar nerve passes through here, and in zone 1 is a motor and sensory branch, right? In zone 2, it's only motor. And in zone 3, it's only sensory, right? Now, if I'm looking at this, this is going to be the ulnar side, right? Obviously, that's why I drew those other things for you. And then this is going to be the radial side, right? So that ulnar nerve passes through, and you see this branch is both motor and sensory, and then in zone 2 and 3, it divides. One is motor and one is sensory. On the zone, the ulnar side of zone 1, you have the FCU and then the pisiform, right? So that creates that one. On the dorsal end, you have your FDP, and then your transverse carpal ligament. Okay, so I'm gonna write here, this is the dorsal. So we always look at anatomical, right? So if this is my pisiform, this FDP is underneath that nerve, right? And then this is on the side. And then you have your carpal ligaments. And these are volar. Volar. They're both on top and on the side, right? So I think really the most important thing to know is like this. What muscles kind of run by it. On the motor side, you're going to be flanked ulnarly by the abductor minimi. So the abductor digiti minimi is going to be on the ulnar side. And then on the dorsal side is going to be your palmaris brevis. And then over here on the third one, you also have your abductor digiti minimi and your palmaris brevis. And then on the radial side, you just have your long flexors. So the most important thing I think to know is that in this particular area of the ulnar tunnel is that you have that branch that then breaks up into motor and sensory. And then I think the most important thing is just to know like certain muscles, like the abductor is going to be on one side, and then for the motor and sensory branch, you're going to be flanked by the FCU. So these are things that potentially are putting pressure onto, you know, the area. When they talk about motor and then just sensory, only sensory change of the ring finger and the small finger is what differentiates an ulnar tunnel versus like a cubital tunnel if they only have sensory, right? Because it's so distal. But out of all these zones, zone number 1 is your most common zone to get compressed. Just like, you know, when we talked at the elbow, the most common part for the compression is the cubital tunnel.